Oxygen is terrific for a hangover. It's also, of course, vital to life, and it's distributed around our body via the cardiopulmonary functions of our heart and our lungs. Whenever you're treating a casualty, you have to check that all those processes are working properly. That is as simple as A, B, C, D, E.
A stands for airway, with cervical control. B stands for breathing. C stands for circulation. D stands for disability, and E stands for exposure. Further assistance in how to approach the checks and record your findings can be viewed on the section of the International Cruciform card headed Primary Survey. This is the term given to this initial assessment of a casualty. Follow the route suggested and record your findings in the spaces provided.
Tilt the head back, open the mouth.
Thanks very much. But looking after a casualty's airway may involve far more than just tilting the head back. A medical aider could find themselves having to clear excess fluid from the oral cavities. They could even find themselves having to insert an oropharyngeal adjunct into the airway, and it's easier to use than it is to say.
The main causes of impaired consciousness levels are due to structural damage to the brain, loss of blood volume, or when a casualty's supply of oxygen is reduced. As the airway takes priority in the treatment and care of any casualty, it's important to monitor the airway of those with impaired consciousness. When dealing with casualties who display different levels of consciousness, assess the level of response by using the AVPU scale. A means they are alert.
Hello, Mark. How are you feeling?
The casualty will readily open his eyes and answer verifiable questions correctly. V means voice.
Mark.
To get a response, you give a command. For example, open your eyes.
Can you open your eyes for me?
The casualty should be able to answer simple questions and obey further commands. Speak loudly and clearly, and remember they may have suffered hearing damage if they've been involved in a blast or explosion. P stands for pain.
Mark.
To achieve a response, you need to apply pressure to the nail bed of the casualty's thumb.
I'm just going to squeeze your finger, okay?
It's important to note how they respond, as it can be another indication of their condition.
Just going to take this pillow off of you, it'll make you more comfortable.
If the casualty responds to testing of A, V or P, support them in a comfortable resting position and continue to observe and record their levels of response. U means they are unresponsive to stimuli, and it's likely their airway is at risk.
Look in your mouth.
In such cases, insert an oropharyngeal, Guedel airway. This prevents the relaxed tongue from falling back and blocking the airway. The Guedel airway is a useful aid in maintaining the airway of the unresponsive casualty.
This will make you feel a lot better.
If you discover the casualty has a gag reflex, do not force insertion of the airway. Remove it if the casualty's level of consciousness increases sufficiently for the gag reflex to return. If at any time you think that the breathing casualty's airway may be compromised, place them in the recovery position appropriate to their condition. This may involve log rolling a spinal case, for example. Suction may be required in cases where the casualty vomits or where there is extensive bleeding in the mouth. It is advisable to ensure availability and efficient use of suction equipment in such circumstances. There are two suction devices available: electric suction, which might be a fixed or portable arrangement, and manual suction, which can be a foot or hand-operated device. The electric device is provided with a selection of catheters which must only be used to remove fluids from the mouth. At no time should the catheter extend further than the molars at the back of the mouth. The most commonly used catheter is the Yankauer, which resembles the type a dentist might use. While suction is one of the options available to you to clear blood, vomit and fluids from the airway, other obstructions such as debris or leftover foodstuffs can be swept away with your finger. Items lodged in the windpipe can cause asphyxia and should be dealt with quickly.
Oh, Neil, how you feeling there now, buddy?
Continue to monitor their airway, and if it's necessary to move the casualty, place them in the recovery position whilst in a basket stretcher, securing them firmly with padding and straps provided.
If a casualty stops breathing, in this case Annie here, then we have to resuscitate her by means of blowing oxygen into her lungs, which is then redistributed around her body. You were marvellous.
As a means of treating a casualty, rescue breathing relies on the fact that the casualty's heart is still beating. Aids to rescue breathing are available on board. The pocket mask offers both the user and the casualty a reduced risk of cross-infection. The bag and mask, often combined with a supply of oxygen, is another method by which ventilation can be achieved. The protocol for administering rescue breathing follows the initial assessment for ABC. Turn the victim onto their back if they're not already in this position. Place the pocket mask over their mouth and nose, holding it firmly in position to ensure for a good seal. Open the airway and blow steadily into the mask whilst watching their chest. In cases where a spinal injury is suspected, it's more appropriate to perform the jaw thrust technique. Take about 2 seconds to make their chest rise, as in normal breathing. Maintaining the airway, take your mouth away from the mask and watch for their chest to fall as air comes out. Take another breath and repeat the sequence to give 2 effective rescue breaths in all. If you have difficulty achieving an effective breath, recheck the victim's mouth for obstructions. Check their clothing, isn't restricting them. If it is, loosen or remove it. Recheck that you have effectively opened the casualty's airway. Make up to 5 attempts in all to achieve 2 effective breaths. Even if unsuccessful, move on to assessment of the circulation. If there are no signs of circulation, or you're at all unsure, start chest compressions. With your hand that is nearest the victim's feet, locate the lower half of the sternum or breastbone. Using your fingers, identify the lower rib edge nearest to you. Work along the ribs, moving to the point where the ribs join the sternum. With your middle finger on this point, place your index finger on the sternum itself. Place the heel of your other hand next to your index finger. This should be the middle of the lower half of the sternum. Place the heel of the other hand on top of the first. Extend or interlock the fingers of both hands and lift them to ensure that the pressure is not applied over the victim's ribs. Do not apply any pressure over the upper abdomen or bottom tip of the sternum. Position yourself directly above the victim's chest and with your arms straight, elbows locked, press down on the sternum to depress it between 4 and 5 centimeters. Release all the pressure without losing contact between the hand and the sternum, and then repeat at a rate of about 100 times a minute, a little less than 2 compressions a second. It may be helpful to count out loud. Compression and release should take an equal amount of time. After 15 compressions, give 2 effective breaths. Return your hands without delay to the correct position on the sternum and give 15 further compressions, continuing compressions and breaths in a ratio of 15:2. Only stop to recheck for signs of a circulation if the victim makes a movement or takes a spontaneous breath. Otherwise, resuscitation should be continued until qualified help arrives and takes over, the victim shows signs of life, or you become exhausted. Two-person CPR is less tiring than single-person CPR. However, it's important that both rescuers are proficient and practiced in the technique. Therefore, it's recommended that this technique is only used by trained healthcare providers and those laypersons who are members of trained teams, such as yourselves and other rescue organisations. If the victim starts to breathe normally on their own but remains unconscious, ensure for continued observation and management of their airway, and be prepared to restart rescue breathing if necessary.
Every vessel has one of these on board. It's an automated external defibrillator for people who've gone into cardiac arrest. Now, obviously, the AMA will know how to maintain and to prepare it.
Ventricular fibrillation is the most common cause of cardiac arrest. It's a rapid and chaotic rhythm of the heart where the heart is unable to contract and therefore can't pump oxygenated blood to the brain and other vital organs.
Okay, stand clear.
Efficient use of the AED will deliver a controlled electrical shock which may restore the organised rhythm in the heart to enable it to contract and pump blood. Death from ventricular fibrillation occurs within minutes. The sooner the shock is provided, the greater the chance of survival for the victim. The advanced medical aider on board the vessel has been trained in its use and will appreciate your assistance in its preparation and maintenance. Every system has its own protocols, and it's important you become familiar with the manufacturer's instructions. The battery supplied should last between 3 and 5 years if looked after properly, and a fully charged spare should be kept available. As in all cases of treatment, a full record of AED usage should be detailed on the documentation allocated to the casualty. Once you've dealt with the immediate concerns as regard the casualty's airway, breathing and circulation, you can proceed to perform a physical examination. Remember, the casualties may indicate immediate problems or show signs of symptoms that can help in identifying any problems. If possible, use an assistant to record your findings on the triage cards provided. Please speak to the casualty and observe their reactions throughout your examination. A thorough examination should start at the casualty's head and work down. In all cases, be aware of the potential for spinal injury and take appropriate precautions.
Just got to check your neck, mate. Just shout if you feel any pain.
At the head, run your hands over the scalp, checking for bleeding, swelling, or depression. Look for fluids coming from the ears or nose. Speak clearly to the casualty and check for their response. Examine their eyes. Their pupils should be of equal size and react to light. Note any bruising, bleeding, or foreign objects. Look for any signs of shock, blueness to the lips, cold, sweaty skin. During this examination, you may have to remove clothing, but ensure that the movement of the casualty is kept to a minimum.
Just got to cover you with this blanket.
Use a blanket to keep the casualty warm and to retain their dignity during the procedure. Observe the casualty's chest as they breathe. Note whether it expands normally.
Right, just got to feel along your collarbone. Shout if you feel any pain at all.
Gently feel along the collarbones and shoulders.
Just got to move your arm a minute. I'm just going to lift it up. Okay.
And check the mobility of the arm joint. Check for abnormal sensation in the limbs.
Okay, eyes, fingers, and everything's fine.
Feel the ribcage for deformity, irregularity, and tenderness, observing the casualty's reaction as you do so.
Okay, chest and ribs seem fine. Okay, you might feel a wee bit of pressure on your abdomen. Yeah?
Feel the casualty's stomach for any rigidity or tenderness.
Okay, his abdomen seems fine. Okay, mate.
Look for evidence of a pelvic fracture in advance of a physical examination.
Yeah. Okay, the pelvis
Check for signs of blood loss or incontinence in the area. Only feel the pelvis for signs if none are evident.
Okay, there's no blood on the left side.
Examine each leg in turn, looking for bleeding, swelling, deformity, or tenderness and mobility.
Okay, there's still no blood or fluid.
Finally, check for movement and feeling of the feet. Abnormalities could indicate circulatory problems or possible spinal injuries.
Okay, mate, just cover your back up.
Having completed your examination of the casualty, refer to the Casualty Assessment module for the cruciform card to guide you through any remaining aspects of survey and management.